how many people have been impacted thus far and how the hospitals have impacted and essentially what this means for both hospitals and Minnesotans.
Right. Well, the initial population, as you said in your introduction, has been about 85,000 people are now in the Medicaid program before, but not all of those folks were uninsured. And this is one of the reasons that we really felt it was important for all policymakers to understand. Minnesota was already providing coverage for about 50,000 of those folks, either on the General Assistance Medical Care Program or in Minnesota Care. So not all that population was uninsured. And as we look at the expansion going up to 133%, likewise, a lot of those folks are on Minnesota Care too. But potentially, in answer to your question, it would be about an additional 95,000 people who are either uninsured or on Minnesota Care.
Do you think the state has benefited from this move, particularly because it's moving these people from, as you said, state-funded programs into a federally funded program instead, and there have been some financial impacts to the state thus far?
Right. Well, a couple different. There's both the care side of that question as well as the financial side for hospitals. Hospitals, physicians, dentists, chiropractors, all healthcare providers, we have to pay that 2% provider tax that supports the Healthcare Access Fund, which supports the Minnesota Care program. So obviously moving to a program that is funded through general tax dollars rather than the provider tax is obviously better for hospitals. But even from a care point of view, the Medicaid program has a different benefit set than the Minnesota Care program does. Minnesota Care has a sliding fee scale that people have to pay. It has a $10,000 cap. So it is not usually considered as good a benefit set as the Medicaid program is. So it's been better for the individuals too.
And as we've recently, as we talked about real briefly, the Affordable Health Care Act, or we'll also call it the Obamacare because that is, it's a loosely
commonly known as.
Absolutely. And recently the Supreme Court did rule on it, and the Medicaid enrollment portion was singled out in that ruling, with the High Court stating that essentially states cannot be forced to opt in and risk losing federal funds. So is there any angst with this decision?
Well, actually, it was, when in reading the decision, the words that Judge Robert used were gun to the head, which is kind of funny for a Supreme Court justice to use the terms gun to the head. But what this High Court ruled was they didn't want states to suffer the enormous penalty of losing all of their Medicaid dollars by not doing the expansion. And if you step back from that and think about nursing homes and home care and other folks already on Medicaid, if a state opted not to do the expansion, they would in essence have lost all of their federal Medicaid dollars. So what the Supreme Court ruled was that was too high of a threshold to make the states do that. They said in the wording was that it could be a minor penalty, but not one of that magnitude. So obviously there's a little bit of play here. What does that mean as a minor penalty? So we'll have to work on that. The states do have the option now of not doing the Medicaid expansion. In looking at what has happened in the last just few days, a number of the Republican governors are trying, I think, to piece together options that might give them a little more flexibility in the Medicaid program, but perhaps still move forward with the Medicaid expansion.
Do you think this ruling by the Supreme Court perhaps opened up an entire can of worms that didn't exist before, like more questions instead of fewer?
Well, that's interesting you asked that, Julie, because I just have read a copy of a letter from the national state Medicaid directors. Every state has a Medicaid director. We have one. These are really smart folks who have asked a lot of questions like, do you have to go up to 133%? If you don't go up to 133%, are you still going to be eligible for the 100% federal participation? Another question that a lot of folks are asking, do you have to do it in 2014? Can we ease into it as a state, doing it in 2015 or 2016? So they're asking a lot of now implementation questions that aren't necessarily negative, but it does mean we are going to have more of a state-by-state program rather than a national threshold. So every state is going to have slightly different criteria and different program in Medicaid, which ironically is kind of the way we have it now. So.
Mary, let's move away from the Medicaid portion and talk a little bit more about the big picture. Obamacare, of course, requires people to have health coverage, or they do face a fine. So what I'm curious is, once it's implemented and people have had time to shop around and hopefully get get the insurance that they're supposed to have. So if somebody turns up to a hospital without insurance, A, will they still receive care? And B, is the onus on the hospital then to turn this person in? How do you expect that to work?
I think one of our biggest concerns, quite frankly, with the exchange is that a lot of low-income folks will be given a subsidy to buy insurance. Will they actually do that? Will they be able to maneuver the health insurance exchange and make that happen? But the amount of subsidy, are they more likely to buy a high deductible health plan? Now, high deductible health plans have worked great for a lot of people. I don't want to be against all high deductible health plans, but for low income folks, most people aren't able to pay those deductibles. So what the hospital will see is still some uncompensated care associated perhaps with a $6,000 deductible, $10,000 deductible. Will Minnesota set a threshold on how high those deductibles can be? So in answer to your question, the hospitals will still have some uncompensated care.